Hello, everyone. Welcome to CLU's very first webinar. We are doing this series in response to the outcry that we have seen from Black women in the US. This webinar is for free CME. It's structured for healthcare providers. This is a slide essentially about how to access your CME after the webinar is over. This should count for 1.0 AMA PRA credits. Before we get started, I wanted to say a welcome to all of our panelists who have been able to join us here. We have with us 4 panelists. We may have a 5th. She's having some connectivity issues. We have with us today Dr. Karen Scott. She is a OBGYN at UCSF, and she's an associate professor there, and she is a foremost expert in reproductive health disparities. And she will talk to us about what reproductive health disparities are and her research. And after her, we will hear from potentially Dr. Joya Krier-Perry, but then we will hear from Dr. Donna Davis, who is a professor at, oh my gosh, SUNY Downstate, right, Dr. Davis?
No, I'm at the Graduate Center, but I thought it was, yeah.
Yeah. So it depends on if Dr. Joya Krier-Perry is able to join us. So I'm sorry, before Dr. Krier-Perry, it will be Dr. Deidre Cooper Owens, and she'll talk about the origin of health disparities and the history behind that. And then it'll be Dr. Davis. And then Dr. Davis is followed by Miss Nicole JeanBaptiste, who is a doula and a community organizer. So let's start so we can make sure we have time for questions. Dr. Scott, if you wouldn't mind starting us off.
Yes, please go ahead and proceed with my slides, please. Okay, thank you, Dr. Bray and CLU for this opportunity, and much admiration and RJ love to my esteemed panelists. I'm honored to help frame today's discussion as the first speaker. Next slide, please. I first want to share that I'm the maternity care quality improvement expert for the Merck for Mothers Safer Childbirth Cities, Atlanta, with Black Moms Matter Alliance. Next slide, please. So let's begin with the future, actually. Reproductive justice, or RJ, was coined by a group of Black women in 1994 to reflect a growing movement to advance human rights and social justice for the most structurally excluded and oppressed communities of Black, Indigenous, and people of color. RJ posits that every person has a right to decide if and when to become pregnant and to determine the conditions under which they will birth. Every person has the right to decide they will not become pregnant or birth a baby, and the right to a full spectrum of accessible options for preventing or ending pregnancy that are approachable, acceptable, available and accommodating, affordable and appropriate, especially for the most structurally excluded and harmed among us. Individuals have the right to create their family and to nurture, nourish, and protect the children they already have with dignity and with the necessary social supports in safe, sustainable, and thriving environments and healthy communities, without fear of violence from the individuals or the government. And finally, individuals have the right to disassociate sex from reproduction, and that healthy sexuality and pleasure are essential components to whole and full human life. Reproductive justice mandates leadership be centered among Black, Indigenous women people and women people of color. Next slide, please. So just because you work in the area of reproduction does not automatically qualify you as an agent of RJ. Each framework offers different, distinct assumptions and approaches to do this work. You can check out the link for more details, but the reproductive health framework focuses on it's grounded in a social and health services delivery model. The reproductive rights framework focuses on legal, legislative, and/or administrative advocacy model that relies on the courts to secure and protect rights at the local, state, and federal level. And the RJ framework focuses on structural and systems change to activate and restore self-determination and power for, by, and with the most structurally excluded and harmed women, people, and communities across intersectional forms of oppression and abuses. Next slide, please. The statistics you'll see on this slide can be found on the World Health Organization and the CDC website. So a health disparity refers to a difference in the health status of different groups of people. In contrast, a health inequity is defined as a difference in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. Health inequities are unfair, avoidable, and could be reduced by the right mix of institutional and governmental policies and reparations. We must acknowledge that structures and systems are in place around the world and in the US that deny health care, including sexual and reproductive health services and support, as a human right. Different types and levels of racism, sexism, gender oppression, language barriers, ableism, and other intersectional oppressions within our health system and academic training centers continue to create and facilitate mistrust and fear within communities, negatively impacting health and health-seeking behaviors and healthcare outcomes and experiences. In communities where sexually transmitted infections or STI, where the prevalence is higher, because of these and other factors, people may experience difficulties reducing their risk of STIs. With each sexual encounter within their social and sexual network, they face a greater chance of encountering an infected partner than those in lower prevalence settings do, regardless of similar sexual behavioral patterns. And as you'll see from the data, two dominant groups have the right to experience sex, pleasure, partnering, pregnancy, and childbirth without the perceived or actual fear of death or severe complications. Next slide, please. So congenital syphilis, or CS, is 100% preventable. Half of US cases of CS in 2018 occurred due to gaps in testing and treatment during prenatal care. Nationally, the most common missed opportunities for preventing CS cases occurred when mothers were diagnosed but not adequately treated for syphilis, representing 31% of cases, or mothers did not have timely prenatal care, presenting 28% of the cases. So prevention gaps also differ by geographic region. Nearly 90% of CS cases were in the South and the West. In the South, lack of adequate treatment was the most common missed opportunity for prevention. And in the West, lack of timely prenatal care was most common. And as a former CDC-funded STD fellow in California who triaged the online provider consultations, two of the most common barriers in control of syphilis and CS at the provider and systems level was lack of knowledge and appropriate screening, diagnosis, and treatment, especially for people who are pregnant, and lack of knowledge, comfort, and confidence in conducting a trauma-informed, gender-affirming sexual history. Next slide, please. So access to and utilization of assisted reproductive technology, or ART, is crucial to protecting and advancing the basic human right to create biological and social kin, or family. However, data tell us that Asian and Pacific Islander and white non-Hispanic people had the greatest number of ART procedures in 2014 among women and people, approximately 6,000 and 3,000 compared to 1,400 among Black people and 800 among Native and indigenous people. So data about ART cycles in 2014 to 2016 showed very grim facts about the experiences of Black women, being older, being likely to have poor ovarian reserve, higher percentage of tubal and uterine factors, higher BMI, lower ratio of live births, and higher miscarriage rates. Using statistical methods, the researchers found that race, and shout out to Dr. Joya, who's pushed the national conversation to say racism and not race, was an independent factor related to a live birth, even when controlling for age, BMI, previous pregnancy, and etiology of the infertility. The authors conclude that state infertility insurance and mandates seem to be an effective structural, not individual level, intervention in addressing racism as a driver of inequities in access and utilization to ART. Next slide, please. So the pregnancy-related mortality ratio, or PRMR, yes, is defined as the number of deaths during pregnancy, childbirth, or within 42 days after 100,000 live births. So in 2018, the PRMR for the US was 17.4, placing the US 55th compared to other countries in the WHO latest PRMR ranking, just behind Russia at 17 and just ahead of the Ukraine at 19 deaths. Currently, the US health system watches and facilitates this death gap, with the highest rate among Black mothers and birthing people at 40.8 deaths, compared to the lowest ratio of 11.5 among Hispanic women. Last, the PRMR among Black women with at least a college degree remains 5 times higher than white women with similar education, Well, education is not going to save us. Next slide. It's important to know that the fact is 60 to 7% of pregnancy-related deaths are preventable. Thus, racial and reproductive health inequities persist. This means 30 more Black women can still be alive and here with us and their families today. Next slide, please. So for every one maternal death, 100 women suffer severe maternal morbidity or SMM, a life-threatening diagnosis, or they undergo a life-saving procedure during their hospitalization for their birth. This means 4,080 additional Black women experience a near death or a near miss. So using the SMM rate as a key performance indicator, then what does your SMM rate say about your past, present, and future commitment to Black people-focused anti-racism and reproductive health rights and justice? Next slide, please. We can no longer deny the historical and contemporary experience of reproductive and perinatal apartheid in the United States health systems. I define reproductive and perinatal apartheid as a system of racial and ethnic separation rooted in a hierarchy of value, power, potential, knowledge, and participation based on skin color, resulting in the pursuit, provision, and proliferation of safe, respectful, dignified pregnancy, labor, childbirth, and postpartum for a dominant group. This specific type of apartheid is manifested in different ideologies, policies, practices, procedures, and power within and across different systems such as healthcare, housing, education, judicial system, law enforcement, labor workforce, and family, leading to differential care, experiences, options, opportunities, and outcomes. Next slide. So in closing, I lead a team under the Sacred Birth model that has created new theories, methods, and measures based on providing novel language and meaning grounded in the voices, wisdom, lived experiences of Black women serving community organizations, Black women scholars, including Dr. Donna Ian Davis. Next slide. And a community-driven perinatal quality improvement prioritization protocol. And next slide. The Participatory Patient-Reported Experience Measure of Obstetric Racism, aka the PREM-OB scale, that consists of 7 independent validated scales to assess patient and community-driven quality of care domains. And yes, the study enrollment is alive. And next slide. Happy National Midwifery Week in 2020 is still the year of the nurse and the midwife. Thank you. Next slide. Thank you very much.
Thank you, Dr. Scott. That was amazing. Thank you so much for that. Now we'll have a couple words from Dr. Deidre Cooper Owens, who is a foremost scholar and historian in both medical history and racial history in the United States. Can you give us some perspective on where do these disparities come from, Dr. Owens?
Sure, thank you. I am, as I'm getting my screen ready here, I hope you all can see this. First, let me do what folk from the US South always do and just say how grateful I am to be here. Thank you to all of the participants who are tuning in, and I consider it my good pleasure to be on this panel with each and every one of you. So the disparities really come from the history of quote unquote formalized obstetrics and gynecology. And often in the United States, historians, I should say earlier historians, have really done, I feel, a disservice to the field. Because what they have done is create a kind of great man or great woman view of history. And what it does when contemporary audiences often learn of the history, we create historical boogeymen, right? Or historical boogie women, so to speak. And so in the US, that has often revolved around James Marion Sims, who was known as the father of American gynecology. In my work, I tried to dismantle this binary that somehow one person, and in the case of the US, Sims was exceptional. And I showed that, in fact, you can see from the names that I've listed on this slide, from Georges Cuvier, who's French-born and did experimental work on Saartjie Baartman or the Hottentot Venus, Ephraim McDowell, known as the father of the ovariotomy, John Peter Matar, who pioneered the surgery that James Marion Sims had done, obstetrical fistula surgery, and Francois Marie Prevost, who did experimental work on enslaved women in Haiti and Louisiana, trying to perfect the C-section. All of this happened before Sims was even in medical school, right? And so what I'm trying to do is show that these disparities come around because of the building blocks of American gynecology and obstetrics that were really built in concert with the strengthening of slavery as an economic labor institution. And so these men tended to have access to enslaved women's bodies to perform these kinds of experiments, largely because, right, you can go to the owner and tell them that you will, in a legal sense, repair damaged property, particularly if the enslaved woman has issues surrounding her reproductive health and capabilities. But beyond that, you don't need consent. That doesn't exist for a human being who is labeled as movable property or chattel. And so what happens is those men are essentially trying to secure their own economic wealth, because slavery is perpetuated and maintained in the United States from the colonial era all the way to the end of the Civil War, through the birth of enslaved children to enslaved women, because children inherited the status of their mothers who lived in bondage. And so it is really a system where white men and even the state are concerned with Black women's fecundity, but also their reproductive health, and not out of a sense of benevolence or, you know, their kind of magnanimity, but it literally is the increase of economic assets. Now, what happened through all of this, though, is the way in which this history started to be produced in writings and also in teachings. So all of a sudden, although the physicians and the surgeons are writing about Black women as patients, and in certain cases as surgical assistants or nurses, there is an erasure that begins to happen. And within this erasure, it becomes even more predominant in the age of freedom. So after 1865, and all of a sudden, there is a literal framing of Blackness as invisible, right? Now, what happens though, and I tend to pose this question to audiences when I give a talk, is, all right, Black people are quote unquote erased from the historical record, right? Slavery is erased from the historical record. And so what does this mean? What it means is, all of a sudden, the possession of having healthy Black babies being born to women who are able to breed, right, without problem, who have healthy reproductive systems in the age of slavery, changes in the 20th century, the late 19th century, 20th century, and even the 21st century. And Black births are now seen as they're seen as a burden on society. Black women and birthing people are seen as pathological. They are seen as hypersexual. And literally the language begins to change in freedom, right? All of a sudden you have, in the 20th century, the rise of the welfare queen with all of her children who are literally kind of chipping away and eating away at the system, taking away the resources of hardworking white Americans. In the 21st century, you have the tropes of the, you know, sexually irresponsible baby mama. And you also have a reversal. So instead of this kind of laser focus on having Black women have babies during the age of slavery, in freedom, you have sterilizations that happen. Right. You have experimentation in the 20th century that's reminiscent of the 19th century. We can think about the cases of Henrietta Lacks. We can think about folk like Fannie Lou Hamer, the civil rights pioneer in Mississippi, who talked about her own forced sterilization, really unknown sterilization called a Mississippi appendectomy. And so these things start to happen in the 1980s. Women who, especially in urban areas, who received government benefits were forced into getting birth control, right, or not getting their benefits. And so there is a literal reversal that happens, right? And so then what becomes of this, right? What is the legacy of the experiment, the experimentation, the exploitation, right? The legacy is Black women are 3 to 4 times more likely to die from pregnancy-related complications, right? Black maternal morbidity and mortality is the highest in this nation compared to any other racial and ethnic group. The United States is the most dangerous, quote unquote, developed nation to have a baby if you are a Black person, right? And so often when I first started this project, people were asking me, what does slavery have to do with any of this, right? Anti-Blackness. Right? We live in a space where literally the building blocks of American gynecology and obstetrics were built on the exploitation of Black people. And in freedom, what happens is a further devaluation of Black women's lives, where Black births are not seen as financial assets, but financial burdens. And so as you have many of the folk on this panel, many of you who are watching in, right, what we're now confronted with is how do we change the numbers, right? Because we have seen it in the American press. We hear it on radio stations around the world, the BBC, all of those kinds of things. But how can we combat the Black maternal crisis, right? When we know that the U.S. isn't doing what it needs to do. And so essentially, what many of us are continuing to advocate for is that the United States government, and that's going to be challenging considering the kind of state that we're in the United States politically, but that the United States government continues to advocate that medical racism be seen as a public health crisis, but we continue to call out the ways that medical practitioners are being trained, some of the curriculum that they're using. I often point to a 2016 study that comes out of the University of Virginia, one of the most elite schools in the United States, and their medical college assessed almost 300 medical residents and students about their views of Black people and white people who were seeking medical care. And most of those residents and med students believed all kinds of outdated fictions about Black people, right? Black people had thicker skin, Black women didn't experience pain during childbirth. In fact, Black people didn't experience pain. Black people were histrionic. I mean, I could go on, right? So what we're doing is advocating that medical racism be considered a public health crisis, but also that we change the curriculum. Oftentimes, cultural competencies, whether they're well-intentioned or not, is sometimes a recitation of racial stereotypes. And so a part of that is diversifying medical knowledge, working in concert in creating synergistic relationships with all birth workers, whether they be midwives and doulas. And so these are really the kinds of things that we need to do to reverse those numbers and to have a better quality of life for Black women and Black birthing people. I am going to now take a breath.
Yes.
I have never spoken this fast in 10 minutes.
Thank you so much for that. As a medical student, I heard nothing about racism and its impact on healthcare. So that's a lesson also for me to learn, that a lot of medical students are not hearing that. So,
Right.
So now, I'm so sorry, Dr. Davis, that I got your university wrong, but Dr. Donna Ayeen Davis is a professor, a lecturer, also an author, and she's going to share with us her work that actually shows that even if you control for socioeconomic status and education, the defining factor is still race.
Thank you so much. I want to thank Dr. Brayboy for putting together this wonderful panel, and I'm so excited to be working with all of you and to be in this conversation. So there's my disclosure statement. I have no personal financial relationship with any commercial interests relevant to this presentation that existed during the past 12 months. Next slide, please. Thank you. I want to take up the issue of reproductive health disparities, particularly in the present, through the lens of premature birth, which is the subject of my book, Reproductive Injustice, Racism, Pregnancy, and Premature Birth. The book explores how race and racism factor into the lives of Black women who have various degrees of higher educational attainment, were pregnant, had given birth prematurely, and had their children admitted to a neonatal intensive care unit. Their pregnancies cover a very wide time frame from the 1980s to 2016. Because Black women have the highest rates of premature birth in the United States, I think it is fundamentally important to trace the imprint that racism has on pregnancy and premature birth. And I accomplished this goal by conducting research that began in 2011 and is ongoing, although the book reflects research that took place from 2011 to 2018. To date, I interviewed and spent time with 23 parents, including 3 fathers, 5 administrators from the March of Dimes, 11 birth workers, that means midwives and doulas and reproductive justice advocates, 17 hospital-based personnel, including 7 neonatologists or residents, 1 retired obstetrician, 8 nurses, and a social worker. The hospital staff worked in Connecticut, Florida, Louisiana, Minnesota, New York, and Ohio. And I also spent time at neonatal intensive care units in Louisiana, Minnesota, New York, and Connecticut. And I contextualized contemporary experiences that Black women have had during their medical encounters by drawing on archival material. In drawing on archival material, I am making the point that has been so eloquently and cogently researched by Dr. Deirdre Cooper Owens, that there is this history that informs Black women's contemporary medical encounters and their birth outcomes. This temporal dimension of Black women's encounters and outcomes are revealed by looking at history in relation to more contemporary times. For instance, we can see this relationality in the work of economic historian Michael Haynes. Next slide, please. It's okay, it's kind of small, but one of the most startling things that I discovered back in 2016 was this particular table showing that the rate of racial disparity between Black versus white infant mortality, premature birth being the primary cause of infant mortality, in 1850 was lower than it was between those two groups in the year 2000. In other words, in 1850, the rate for Black infant mortality was 1.5 times higher than white infant mortality. And in 2000, although the numbers dropped, the disparity was 2.5 times higher. So one of the contributions that this book makes by virtue of who is included in the research, Black women with some college, who have college degrees or advanced degrees. And by focusing on them, I'm able to shift the conversation from the popular belief that the mascot of adverse birth outcomes can mostly be attributed to low income and poor Black people. So every November, I want to just talk briefly about the current state of Black women's premature birth experiences. Every November, which is National Prematurity Awareness Month, the March of Dimes publishes the premature birth rate card. The most recent report from 2019, which uses 2018 data, revealed that the overall premature birth rate in the United States in 2018 was 10.2%. But among Black women, that rate was 13.6%. In other words, the rate of preterm birth among Black women is 49% higher than for all other women. Additionally, the March of Dimes has found that in averaging data for the years 2016 to 2018 in the United States, cesarean delivery rates were highest for Black infants, 35.4%, and lower for Asian Pacific Islanders, whites, American Indian, Alaska Natives. It is very typical for research to point to individual deficits, such as race, to explain these outcomes. Indeed, some research suggests even epigenetic factors as an explanatory factor. However, my research centers on racism, not race. In other words, I'm asking, how do Black women interpret and give meaning to the medical encounters and practices of racialization that they believe mediates their birth outcomes. My findings reveal the following. If we draw from Black women's lived experiences and their narratives, we can understand what racism feels like. Not how it gets socially or historically constructed, but what it feels like. Another finding is that Black women with access to healthcare and what we call social and cultural capital, such as employment, insurance, education, and support systems, confront various forms of racism, from the subtle to the blatant, during their medical encounters. So therefore, relying solely on a class analysis to understand outcomes is to de-emphasize the fact that providers' clinical decisions may indeed have something to do with those outcomes. Next, we need to challenge the medical paradigm that over-medicalizes birth and does not view pregnancy, labor, and birthing as cooperative endeavors between patient and provider. We need to focus on racism as the risk factor connected to birth outcomes rather than race. So consequently, I suggest that we rethink the concept of racial disparity as the problem in need of solutions, and rather focus on the fact and admit that racial disparity is caused by racism. Racism is not a social determinant of health. Social determinants of health arise from structural determinants, which are produced by racism, as Midwife Jessica Roach says. The ways that Black women experience racism comes in a number of forms, and since the book, I have developed an explanatory framework to explore the content of those experiences, and they are what I call obstetric racism. Next slide, please. By obstetric racism, I mean the mechanisms of subordination to which Black women's reproduction is subjected that tracks along histories of anti-Black racism. As an analytic, the concept highlights forms of violence and abuse that medical personnel and institutions routinely perpetrate against Black women during conception, pregnancy, childbirth, and postpartum. It is comprised of beliefs and practices leveled against the reproducing Black body, and it sits at the intersection of two concepts, obstetric violence and medical racism. Obstetric violence characterizes situations when obstetric patients are controlled and subjected to dehumanizing treatment by medical professionals and staff. Medical racism occurs when a patient's race influences the treatment or diagnostic decision in the broad context of medical provision and involves the racialization of the Black body, such as thinking that Black people are more or less susceptible to particular diseases. Obstetric racism locates the specific ways that reproducing Black bodies are subjected to medical intervention and harm. And through it, we gain a deeper understanding of the impact of the logic of racial domination on Black women and birthing people at any point in their reproductive lives. Obstetric racism serves as a theoretical framework that can help clarify our understanding of a type of crisis in which the significance of anti-Blackness, which circulates in the most mundane and blatant ways in education, in policy, in service delivery, serves as the rationale for decisions and diagnoses. It does offer a way for scholars and activists and medical professionals to be attentive, not just to race as a sorting mechanism, as a way to identify demographic data, but to racism that permeates obstetric and gynecological encounters. So this slide shows you 7 dimensions of obstetric racism, although I want to point out that it is a flexible framework. And so I'm going to go through each one very quickly. The first is a diagnostic lapses. A diagnostic lapse occurs when a clinician has an uninterrogated belief that Blackness is pathological and leads them to de-emphasize, exaggerate, or ignore a patient's symptoms, resulting in an inappropriate or lapsed diagnosis. For instance, when a woman, because she is Black, is determined to be obese and is then told she will have to have a C-section. Neglect, dismissiveness, or disrespect. This dimension occurs when medical professionals do not pay attention to a person in need of reproductive care and/or treats them with disdain. Next is intentionally causing pain. This is when medical professionals fail to appropriately manage pain, referring back to the obstetric hardiness that Professor Cooper Owens described, and is rooted in racialized beliefs about pain immunity, as well as it is accompanied by an absence of empathy for Black people's physical suffering, leading to a lack of internal motivation to alleviate or reduce Black suffering. So this includes obstetric hardiness. Then there's coercion. Coercion is when medical professionals perform procedures without consent and/or intimidate patients to make decisions, such as telling a patient that their baby will be harmed if they don't have a particular procedure. Then there are ceremonies of degradation. These are the ritualistic ways in which patients are humiliated or shamed, and includes a sense of being sized up to determine the worthiness of the patient or their support person. And either of them may be viewed as a threat. And in response to being viewed as a threat, medical staff may deploy security, police, social services, or psychiatry to ensure compliance or to remove this threatening person. Next is medical abuse. This occurs when medical professionals engage in experimentation or repetitive behavior that is motivated not by concern for the patient, but serves to validate the clinician's self-worth and upholds their domination over the patient. And finally, there is something that I call racial reconnaissance. And this describes the very Herculean effort that Black women make to avoid or mitigate racist encounters, including being hypervigilant about procedures and engaging in a hypervigilance for finding providers. So this framework can and is being translated into a patient-reported experience measure by Dr. Karen Scott, who is validating the only participatory PREM that characterizes the impact of racism and will assist hospitals in demonstrating evidence of advancing cultural rigor and quality improvement. And finally, I want to conclude by saying that it is in fact possible to move closer to justice, to reproductive justice. But what that depends on is that those within the medical system listen to the voices of those who come through the system, who work within the system, and those who work outside of the system. Last slide. I hope it says thank you. Oh, no, they're the works cited.
That's good enough. We thank you for your work. Finally, we're going to hear from Nicole JeanBaptiste, who is a doula. And so she's going to talk about the solution. So we've heard about the problem, we've heard about the history, we've heard about what's happening in present day, but what can healthcare providers do to be allies with patients who feel as though they're not welcomed?
Thank you. Yeah, and I'm going to speak about part of the solution, which are doulas, right? So before I begin, I would like to thank you, Dr. Brayboy, for the invitation to present today. It is my absolute pleasure to share this information alongside such a brilliant group of reproductive justice champions. So can you please move on to the next slide? Thank you. So let's jump right into talking about what is a doula. And I'm so happy that I have the space to thoroughly explain what our role is in these spaces. So a doula is a trained birth assistant who provides physical, emotional, informational, and advocacy support to individuals before, during, and after childbirth. In hospital settings, doulas are not to be considered staff members, and that's really, really critical. Rather, they are an additional member of the laboring person support team, requested and appointed specially by that person. They perform no medical tasks. Doulas provide continuous labor support to pregnant individuals, which includes physical touch, emotional support, non-medical information sharing, and advocacy. Some examples of physical touch commonly employed by doulas are massage, hip squeezes to provide counter pressure to the laboring person's body, and assistance getting into and out of various positions with the ultimate goal of reducing, if not eliminating, discomfort and encouraging labor to progress steadily. Some examples of emotional support offered by doulas are encouraging words such as, "You are doing a great job," or "The surges, aka the contractions that you are experiencing, are perfectly normal and are helping to bring you closer to meeting and holding your baby." Sometimes a simple "you got this" is exactly what a laboring person on the brink of possibly panic needs to hear to recenter themselves and to relax. I'm pretty sure that one thing all birth professionals, OBs, midwives, nurses on the L&D floor, one thing we can all agree on is that relaxation during labor is critical to progress and safety. We can all do our part to help birthing people maintain or achieve this. An example of informational support is a doula explaining to their client in basic everyday terms the utility, the benefits, and the risks of common, sometimes helpful, and sometimes necessary hospital interventions. In my personal practice, I found it helpful to break these terms down so they're easily understood by sharing a bit about past clients' experiences with the intervention, withholding any identifying info, of course, and reminding folks about BRAIN, which is an acronym that means that in most situations, there are benefits, there are risks, there are alternatives, there is intuitive-driven courses of action, and there's the possibility of doing nothing or to make it known that you need more time. And finally, doulas offer support in the form of advocacy when necessary. Dr. Davis's thorough explanation of obstetric racism clearly illustrates exactly why, as doulas, we'd even need to advocate for our clients, especially our clients who are Black and/or people of color. This clear illustration shows why we need to be doing this advocacy and/or support our clients in advocating for themselves. The power dynamic at play during birth in hospital settings, where you have a laboring person in a highly vulnerable state and a team of medical professionals, too often creates situations where this person's requests for time, basic things like privacy, among other things, are disregarded. And so that's where we step in as advocates. This warrants a respectful assertion of our clients' legal rights to informed consent here in New York City and across the United States. That is a legal right. And their human rights to a safe, dignified birthing experience, which Dr. Scott also outlined very clearly. Can you move to the next slide, please? Thank you. Okay, so how can doulas help patients? Oh, I'm sorry, that image is a little blurry. I don't know if it shows up blurry for you all, but okay, it's really beautiful. And I have the image source there, so you can check out this person's Instagram with even more beautiful images during birth. So the benefits of doula care. Let's get into that. The benefits of doula care are supported by consistent, high-quality research. The most recent Cochrane review from 2017 analyzed data from 26 individual studies involving more than 15,000 women. The review's findings include the following benefits to continuous labor support in the form of doula care and no known harms from said care. And those are a 39% decrease in the risk of cesarean births, a 15% increase in the likelihood of a spontaneous vaginal birth, a 10% reduction in the use of pain medications, shorter labor by an average of 41 minutes, and a 31% reduction in reporting a negative birth experience. Let us remember that the way that people remember their experiences also counts. It's not just that we have a healthy mother and/or parent and child. Can you move to the next slide, please? Thank you. So how can doulas and healthcare providers work together? So one of my #1 recommendations is to strengthen the bond prenatally. Ensure that doulas can be present at prenatal visits, for example. That's just one example. I know that with COVID, that can prove tricky, but we found ways to work around that on the virtual stage. I'd like to highlight a 2013 study that was published in the Journal of Perinatal Education on the impact of doulas on healthy birth outcomes, and it concluded that the inclusion of doulas in the perinatal period at a point when behavioral changes can most impact birth outcomes is most effective. Therefore, if obstetricians and other birthing professionals could include a plan of doula support in the prenatal period, adverse birth outcomes associated with the lack of social support for birthing people in general could be reduced. This would benefit the birthing people and babies, medical practitioners, hospitals, and the greater community in reducing the financial and personal costs of adverse birth outcomes. And that was a quote directly from that article. The second recommendation I have is that during labor, healthcare providers and doulas view themselves as teammates with a shared objective of supporting pregnant people to achieve safe, satisfying births, where the baby and parent remain healthy and respected. What we know is that Black birthing people overwhelmingly report feeling disrespected, as highlighted by Dr. Davis's work and the other panelists here today. We report feeling disrespected and not listened to by our medical providers during labor, resulting in negative, traumatic, even birthing experiences. Respect looks like providers listening to their patients, right? We are telling you, based on countless experiences, that it requires a greater depth of awareness of doing so, of listening to folks when your patients are Black, okay? Respect for one's patients includes acknowledgement of and an earnest attempt at collaboration with their chosen doula, who is their hired support professional. So I mean, I could name many examples of stepping into a labor and delivery room with my client where not only my client was disregarded, but I was as well, you know, and that is an extension of disrespect. I do not respect your choice to appropriately choose a support person for this really important time in your life, is essentially the message that we're being told. So, and sometimes, and we want to make that none of the time across the board. And the following recommendation I have is to provide follow-up care in the months immediately following delivery, including information about postpartum doula services. As doulas, we are, it's very often assume that we focus only on people who are pregnant and folks in labor, when our work extends far beyond that, right? So this idea, this truth that there is support for you during the postpartum stages. And the reason why this is so critical is because we know that a large majority of the cases of maternal mortality and morbidity happen post-birth, right? So that support is even more crucial. And I would also advocate for information sharing around counseling and infant feeding services. Next slide, please. Thank you. All right, so insurance coverage of doula services. Doula support in general is an out-of-pocket expense. At best, private insurance companies reimburse patients for a portion of doula service fees, depending on the cost. Medicaid currently does not cover doula services, although the cost effectiveness of doula care is very well documented. As previously mentioned, continuous labor support from a doula results in an almost 40% decrease in C-section rates. The cost of a cesarean birth is about 50% greater than vaginal births. The table here demonstrates how current pilot programs deeply undercompensate doulas. In Kings County in Brooklyn, New York, where a Medicaid doula pilot program was introduced, it was overwhelmingly rejected by doulas in the region due to its inequitable compensation rates. Medicaid pilot programs are in need of serious redesign with the input of Workforce members ourselves. Okay, and then you can see here from the chart that in this first section of the New York doula pilot program, the idea is that doulas are paid almost half in most cases of what other community-based doula programs are compensating their doulas. Can you move to the next slide, please? Thank you. All right, so I want to get into the importance of community-led grassroots organizations in tackling the issue at hand. So, and I'm going to close with this to encourage providers of Black, Indigenous, and people of color to explore the existing community support systems to which your patients turn when in and out of crisis. And I'm doing that because these organizations are trusted by your patients for good reason. Pictured above on the far left and right are images of me in some way honoring a Black birthing person who died in a hospital during childbirth. I would not be myself if I did not take the opportunity to say these people's names. They are Shaisha Washington of Brooklyn, New York, and Amber Isaac of the Bronx, New York. In response to the death of Amber Isaac, I joined forces with two other comrades in birth work and justice, Carmen Mojica and Evelyn Alvarez, to create a part of the system that, to create a part of the solution, or as we saw it, that for so long has failed us. Not completely sure on how exactly we would show up for community, we'd asked, and community responding with a resounding cry for basic material resources. And so in less than 6 months, we have raised over $50,000 in grassroots funding and donations to support our community. We are doing this without any sustained financial support and as part-time volunteer work. Despite this, we have made over 500 contacts with Black birthing people, providing material resources, and we have begun to build out a network of full-spectrum doulas to care for pregnant people and families in need. We have also started mentoring, training, and connecting pregnant Bronxites, doulas, and midwives. This critical connection is life-saving. My co-founders and I have a track record of supporting healthy births by meeting the complete needs of the birthing person. Can you move to the next slide, please? Thank you. And here is a short list of podcasts, a research report, and powerful storytelling related to the importance of medical providers embracing doula support. I do hope you partake. Thank you.
Thank you so much. Thank you all for participating. We have 107 people who are live with us, but people may see this webinar in the future. It has been recorded and will be enduring content on the platform that you can register for to get the CME. We will now take questions. We did end, I think, a little bit early because we didn't have Dr. Joya online, but Dr. Joya is the founder of NBEC, National Birth Equity Coalition. And you can Google her website and her advocacy that she has done to help reform things. She's been involved in the March for Moms as well. We've missed her presence here today, but I'm so thankful for each and every one of you, Dr. Davis, Ms. JeanBaptiste, Dr. Scott, Dr. Cooper Owens, thank you so much. And we will now take questions. So I'm going to be looking for your questions here in the poll, in the website. Hopefully I can open them. All right. We have a question here from Marie Byerly. What is the relationship of a state economy that is dependent on the local prison system and racial disparities in the reproductive health system? So who wants to take this question? Dr. Scott?
Can you, I'm trying to even understand the question. Can you repeat it?
What is the relationship of a state economy that is dependent on the local prison system and racial disparities in reproductive health?
The state economy and racial disparities, what's the relationship?
I think that's the question. What is the relationship? So the state economy, the local economy is dependent on the prison system, and there are racial disparities, I think, in that same economy.
So I'm gonna speak to what I know to be able to contribute to that, and it may not answer the question, but I don't even know how to start with it. There are, So a reliance on a state economy and a prison system and that's relationship with RJ. So I guess what I can say to my knowledge is that when we think about the criminalization of pregnancy and motherhood, and I can speak to that, that may not answer the question, but that's what I know. When you think about people who have the capacity to reproduce and who are currently parenting, and that would be like women and those who have the capacity to reproduce and parent, that their criminalization actually extracts like the head of households in many homes. So when you think about pregnant people and or mothers and women who have been criminalized and are in the carceral system, usually for low-level crime, and they remain pregnant, that does have a huge impact on who is left to care for the community. So a lot of households depend on women and mothers, and by them being incarcerated, that distorts not only kinship ties, but economic stability of communities. So I know that in California, I helped to push AB 732, which is reproductive dignity for incarcerated people. And so really, again, looking at how the carceral system further impairs our reproductive health rights and justice, looking at the fact that our bill helps to just allow for basic needs as menstrual pads and tampons. So we also in the bill made sure that folks who are pregnant can have access to a support person, whether it be their family or community doula. We also made sure that the reproductive health services for an incarcerated person, like that should negate what the quality of care should be. And when you think about the one population that actually has a constitutional right to health care through the 8th Amendment are people in the carceral system. So we could be doing much better for that population. And so I may not have answered it, but that's my understanding of the intersections of in the carceral system and reproductive health and rights, even just the quality of reproductive health services that are provided while you are incarcerated. It could be like an impairment of your full like reproductive potential, whether you want to end or terminate a pregnancy or to continue to parent. And again, the fact that we have folks who are going into birth prematurely in the carceral system because they are in isolation, we are still impacting like our future. So by having those who reproduce be like the cornerstone of who's now leading and who's getting incarcerated, that could devastate entire communities, particularly Black, Indigenous people of color, also those who identify across the sex and gender spectrum, folks who have substance abuse addiction or who are having unstable housing, who have to use what we call, I hate the term, but the underground economy or different economies, right, to just survive. That I believe that's impacting different communities' capacity to continue to like sustain themselves. But that's my answer that I could think of. I call on the other people on the panel.
Dr. Davis, did you have something to add to that?
I did. I mean, I want to say that first of all, the prison system is rooted in racial capitalism, right. And in the same way that enslavement was rooted in racial capitalism. And mass incarceration and any kind of incarceration by its very nature compromises and undermines bodily autonomy, right? Which is the same thing that occurs in, or did occur in, during enslavement. And so there's a diminished, and if at all existent, a non-existing capacity for people to make decisions, as Dr. Scott points out, about their reproductive well-being. And that inability, I think, really intersects with the state's control of racialized bodies anyway, given that it is predominantly Black and brown bodies that are incarcerated. Right. So, and then there's the fact that just the concept of justice can't exist if we have a carceral state.
Yeah, that's right.
Right. It's counterintuitive all across the board. And so I think the intersections are the way in which the state, no matter where Black bodies are located, choreograph racism and forms of capitalism and reproduction, not just human reproduction, but social reproduction all gets woven together, I think, within the edifice and the practice of incarcerating people.
Okay, thank you so much for those answers. We're going to go on to the next question. This question is from Serena Muzi. I hope I said that right. I'm not sure if you'll cover this, but do you know what the insurance/cost situation is for doulas? For individuals with financial burdens, would they be able to hire a doula for a reduced price? Nicole, do you want to answer that?
Yeah, absolutely. For the most part, across the board, doula care is not covered by most insurance companies. You have a select few insurance companies who will reimburse folks for doula care that they've paid out of pocket for. There are folks working actively to get this changed. One of the main things that we want to see happen is Medicaid coverage for doula care, Medicaid coverage that makes sense and is actually equitable for the provider, the doula. But for folks who are low income and want doula care, my recommendation would be to seek out community-based doula organizations that typically offer free and or low-cost doula support. And depending on where you are, there may be, a great sampling of those, but I'm not sure where this person is.
Unfortunately, I don't know. But I want to say that I had a community doula. I could not afford one when I was a medical student, and she literally saved my life. So I appreciate doulas, and I hope for more collaboration between healthcare providers and doulas. Dr. Davis is also a doula, and so the next question is, what is required to be a doula?
Well, people are very much connected to concepts of certification. I do think people require training, but I also think that certification is one more way to create a hierarchy of people who are able to provide something called compassion. At the same time, sometimes certification, especially in the state of New York, where, tell me if I'm right, Nicole, right, they were going to make us pay some fee to be a certified doula.
Yeah.
So the process typically involves a certification, but what you need to know is you need to know about anatomy. You need to know about various ways in which people can experience comfort. You need to know about the various ways in which people experience discomfort. And as a doula, we're also needing to be attuned to the needs of the birthing person's partner and their familial situation. And their history, and also recognizing, and this is important because you asked what we need, but what do we have to have? One of the things is what we have, I think, many of us, not all, is a degree of humility about what we do. But I think the state believes that doulas are here to help end racism. And I think that was part of the problem in New York, where the governor, I was on that governor's task force, where they were trying to deal with racism through doula care. Doulas, our power comes from our ability to connect with our clients. Yes, we do advocacy work, but the truth is that we're not ending racism. We're not going, we're going to help enhance people's birthing experiences and their laboring experiences. And for that, I think ideally what a doula has, and I don't know if you can get trained on this, is a justice perspective, that we're all entitled to have the best possible both conception, prenatal care, laboring, and birthing and postnatal care experience that a human can want. That's not giving you the specific details of what happens in a training, but those are the things that I think are fundamentally important.
Wonderful. The next question is from Kai Haynes. I hope I'm saying that right. She says hello and thank you, or he says, I'm not sure. Are any of you able to share your public social media presence or contact info so that we may follow up with you if you have any questions? I, as a Black mom and storyteller, have experienced loss, and I am working on some media projects regarding this topic. So people are asking for you to share your information. We actually, as someone who's registered for this webinar, you'll receive a follow-up email asking you about up and coming topics you'd like to hear about, what your experience was with the webinar. And we will also send out the references and citations and also the websites and textbooks that have been addressed here in the presentation. Okay, next question. The next question was about how do doulas get covered, especially by Medicaid? And I think, Nicole, you've addressed that question. But if you wanted to add to that, advocacy, right?
Yes, absolutely. It's really refreshing to see so many folks interested in doula work and care. Yeah, we are in a space where we need folks, we need constituents to raise their voices and make it known that doula care is something that should be covered by not only private insurance companies, but public insurance companies also. So get active, get involved, and find the local activism group working around reproductive justice, particularly birth justice, and make sure that it's on the agenda to lift this up in your area.
Okay. We have someone who practices naturopathic medicine. It says, I've worked with women in the preconception period to improve fertility outcomes, oftentimes related to nutritional health, stress, and advanced age. And I'm trying to see what the question is. Long question. And pre-existing conditions. Okay, to optimize perinatal period experience and knowledge going in. So I don't see a question here, but my question is, how can individuals who are concerned about their birthing experience work with their healthcare provider, work with their doulas, work with the structures, the hospital systems that are in their area to improve their experience?
May I share something from the data that we're doing? So we've completed focus groups and interviews with Black mothers and birthing people across California and also outside of the United States, outside of California, about their birth planning, preparation, expectation, and experience, as well as the information we're getting from interviews with the same group of Black mothers and birthing people about the specific items in our patient report experience measure of effective racism. And it's very interesting to hear from those Black mothers and birthing people who feel that they were able to advance their own autonomy. They were able to make sure they had a safe birth experience. They were able to hold the system accountable. And from those stories, it seems like certain steps were like one mother, Black mother, basically laid it out for me. She looked up the data. She looked up the hospital's statistics around first time low risk first time cesarean births, meaning you're full term, the baby's head is down, you're essentially healthy. And as that group of people, particularly Black women, hospitals are more likely to perform cesarean births on Black women and Black mothers. We don't get a phone call and order a C-section with the side of hemorrhage and a pulmonary embolism and an admission to the ICU. We don't order those things. Hospitals and the lack of quality and accountability facilitating that. So she looked up the statistics. She looked up her office statistics, her provider statistics. She made sure she delivered at a hospital that had a NICU that was a level 3. Not that she was anticipating the worst, but she was planning for like, what are the potential complications that could arise? And I want to be in a system where both myself and my baby will be cared for together. And she picked a practice that, from experiences and reports of other Black mothers, would treat her with dignity and compassion.
Yes.
She did every single thing, and for her, it worked. I'm not saying it's going to work for everybody, but I know that what I'm learning is that some Black mothers and birthing people aren't aware that this data exists. They're not aware that they can ask for these things. We keep saying, go on your birth tour to the hospital. I'm like, on your hospital tour in front of all the other people, ask about the statistics. and ask about what the story is behind the statistics. Like I said, what do hospitals want the community to know and say about them, right? Right. And is it baby friendly? Is it lactation friendly? Do you have lactation educators there, right? Do you have access to mental health services when you need them, not when you are judged as being irresponsible and negligent, right, for wanting to assert your voice. So, and for folks who didn't have that, I've heard that they brought a posse, right? That's why kinship is so important, whether it's your biological kin, partners, grandmothers, the doula, even identifying another Black, brown person on the hospital team, even if it was a non-clinical person. Our data is showing that people like searched for some type of way to connect, to feel safe, to insulate themselves from what was going on, to find some human connection. So there are folks who are realizing if they're going to a place that is hostile essentially and unsafe, it's important that they, they seek a midwife and or a doula, like all of them. Some people are like, I have my doula, my midwife, my partner, my grandmother, like my friends. And with COVID, yes, we know there were restrictions. It also caused people to think of the use of technology, if possible, to make sure somebody, I mean, I've had like this is like there are people on their cell phone in the room with them to make sure somebody was there to be that other ear, right? To be the witness, as Dr. Donna Ian Davis is talking, like people need witnesses. They need to have witnesses to bear witness to their experience, but to also then demonstrate to the system that like, I'm not crazy, you did say this, they heard you, right? That's what we're learning from, and some people have modified their language and their behavior, sadly, but to make themselves more presentable to the system, to make the system feel safer, they code switch. They ask their partners to wear a suit. They put a ring on a swollen finger. I mean, like these are things, and this is a part of the domains that Dr. Davis talks about and what we also gather in our domains, like this modifying yourself to make sure people treat you better, even though they're not going to, but things that we think about doing to try to anticipate, right, potential acts of racism and how can we mitigate.
That's the reconnaissance.
I know, right? That's what the work is so important, right? Yeah.
Dr. Davis, go ahead.
I was just saying that's the reconnaissance
Yeah.
that I was talking about before. But I do want to say one.
Could someone explain code switching? Everyone on the call may not know what code switching is.
Code switching. I mean, I do it all the time.
I wasn't going to explain it, so I wanted Dr. Davis.
I don't even know how to describe it. I just do it. Who does it? Come on.
Dr. Owens, do you want to describe code switching?
I think it's for typically for in this case people who are Black or brown or have been racialized by white folk. It is a way in which we manipulate language to articulate a certain point of view, articulate a message in a more palatable way.
Yep.
Yeah, it's right. It's the opposite of being indexed. You get indexed, you're stereotyped, and so you develop a sort of performance, another kind of consciousness, another presentation of self, so that people will find you acceptable. It's like smiling, you know. Right? I think who is it that said this? Toni Morrison said that Black people smiling is an accommodation to white people's nervousness about being around Black people. So it's like that. I did want to say one thing about the question, though, which is we are having this conversation in relationship to the assumption that the only place that people need to be giving birth is in hospitals. And I just want to say that we need to have other options. We need to have increased support, insurance reimbursement. And first of all, it would be ideal if we just had, no insurance coverage and everybody could be covered. But okay, we're in the United States. That's probably not going to happen. But we need to have more birthing centers. We need to be able to provide support and reimburse people at the same rate if they decide to have a home birth, and assuming, and ideally, a midwife, a doctor, and a birthing center would get reimbursed at the same rate. But people need to have birthing options. Birth is not only a crisis or a risk. I'm not saying that it's not in some instances. But to have that view is to be managing people with a set of expectations that the body is inherently faulty, and Black bodies are already viewed as inherently faulty. And that just gets exacerbated, I think, by the medical system. And part of that comes from how you all get trained. I'm assuming that when you take anatomy classes or took anatomy classes, you only saw white bodies. That's the norm. Brown and Black bodies weren't the norm.
Well, not exactly in where I trained in Philadelphia, but those people don't necessarily donate their bodies to science. So
no, but I'm talking about in the textbooks.
Oh, in the textbooks, yes,
That's
in the textbooks, yeah, for sure.
But that's the other thing. Brown bodies get worked on in those settings, just like, and what Deirdre Cooper Owens is talking about, I mean, she was talking about experimentation instead of practices, but the brown bodies, she called them super bodies. We're just constantly available for everything, right? We're available for people to learn on, for people to make decisions about, clinical decisions about that. And those decisions are intersecting with pre-existing ideas about what Black bodies are capable of or incapable of.
We have time for one more question, and then we have to wrap it up. Oh, yes, Dr. Scott.
Yeah, I just want to shout out Choices Center for Reproductive Health. I have to call out Dr. Nikia Grayson, who is the Director of Perinatal Services, because she's doing exactly what Dr. Donna Davis is talking, what all of us are saying. She is, as I think for now, to date, the only place that has full spectrum reproductive care for trans people, pregnancy, abortion. They support home births as well as a birthing center. So they have a birthing center in the same space as people have abortions. Shouldn't be revolutionary, but it is. And I do
part of being successful is they're not getting federal funds, because we can have models that do require having the state involved in making decisions about what it is you're wanting to do with your body.
And Dr. Scott, where is this center located?
Memphis. Choices, Memphis Center for Reproductive Health, with Dr. Nikia Grayson. And I'm saying doctor because she has a DMP, not because she's a physician, but she is a midwife. She also is a nurse practitioner with her doctorate. She's a family nurse practitioner and a midwife, background in public health and anthropology. She's all of that. And Rebecca Terrell is not the CEO, the CEO and executive director, but they're in Memphis, Tennessee, and she's building a cadre of midwives, and right now has 2 other Black midwives that are with her. So to be in a space in the South with 3 Black midwives supporting home births, birthing centers, birthing in a center, and hospital births is, like, again, shouldn't be radical, is what Dr. Davis calls it, care, but it is. And so I think it's just important that OBGYNs, my call to them, to us, is that we need to learn, radically unlearn all the things that Dr. Owens' work and Davis's work has taught us, that we are part of the problem, if not the driving force of this. And so shout out to Maureen Phipps, CEO of ACOG, for finally having that statement, that collective action, to finally have racism and slavery in one statement from ACOG, the American College of Obstetricians and Gynecologists, is huge. And so I just need to say that out there, is that in 2020, we finally get a statement from work that Dr. Owens has looked at in the 18th, 19th century. We have to interrogate that, why we are just now getting that in 2020. And we deserve more than crumbs. I just have to say that.
No, it's true. And I think a lot of OBGYNs push for that statement. Black OBGYNs definitely push for that statement. So we do thank ACOG for that. We have time for one more question. There are other questions, and I'm sorry we didn't get to everyone's question. This question comes from Tina. She says, how best to address and end racism you also eloquently described? Well, I feel like that would be a whole nother webinar for hours and hours. But the second question, is there even a chance to do so in an inherently racist society? Maybe through policy changes? Does policy change people's hearts?
No, policies don't change people's heart. Punitive actions change laws. And so, as a historian of the United States in particular, nothing has happened because someone felt benevolent towards anybody who was oppressed. They were afraid that something would happen, right? And now I'm not going to code switch. Something will pop off, right? So was a war, whether that was quote unquote rioting or looting. And so what changes is the fear of repercussions from the angry oppressed group. So for instance, slavery doesn't end because slave owners were saying, oh my gosh, in fact, why don't we make these slaves human legally? Why don't we give them freedom and land and the right to education? No, it changed because there was a war and they lost. And so thus, laws and practices had to change to reflect that the Confederacy lost. In terms of medical experimentation and exploitation, things had changed because somehow Black patients were regarded as white patients. We see that in the statistics in the study, from the statistics based on those studies that we've all mentioned. I think what will happen, or what will need to happen, is something punitive.
Mm-hmm.
Like if we go into these places and say, hey, what are the stats? And nothing changes. What's the purpose of understanding the stats if nothing changes? So I'm all for, like, as an educator, let me get enough negative student evaluations. Let me get complaints. Even as a tenured professor, my job becomes more fragile.
Right.
How is that happening for medical practitioners?
It is not. So that's what I would also say. I totally agree with Dr. Owens. It's going to require some popping off. And that's what I do. As the OBGYN, like I was drawn, I literally read Dr. Owens' book and like emailed her, same thing with Dr. Davis. Like it's going to be some of us who, like, I'm just going to speak to myself. I had to call out my contributions to reproductive oppression and injustice as a US trained OBGYN. And I'm from the South. It became the very monster I did not want to become. So I'm constantly unlearning. And I think it's not a bias, it's going to be behavior. We have to call out the behavior and tie provider, physician, I'm going to say physician behavior, to payment, to reimbursement. Money makes this country move. And so that's why part of the scale that I have 7 independent scales, and my funders are like, say 7, because there's not to date a scale that examines patients' feelings, right? Their perceptions, and I learned this from Dr. Davis, of racism, not what institutional, structural, internal, like this is what the patient feels in response to the impact of the quality of care or no care provided. And to have that measure be then a performance indicator that health plans will then look at and determine, wow, this hospital on this scale has fewer reported incidences of racism, they'll get reimbursed at 100%. Where this one over here may have the biggest name, that looks like all your C-sections you performed on Black people, right? Like this, you have higher reported incidents of racism, you will not get reimbursed. And I bet you people will start, like hospitals will begin to create criteria. Maybe that's training, maybe that's multiple trainings in a year, maybe that's a coach or an intervention, like tying people, the grievance reports, the incident reports, right? Really being able to uphold with those who are beneath the hierarchy. And I'm not saying that I support that, but nurses, right, staff, environmental, like all the people who are bearing witness to that, validating those experiences and tying it to a scale and tying the scale to reimbursement. That's what one of the things I'm going to drive for is we have to not reimburse people whose basis of provision of care is grounded in obstetric racism. That's what I feel is what my duty is right now to do. And that's why, and I have 2 health plans as partners so that can happen. So health plans also a part of this because it has, or like even, JCO, like where are those people, right, that give credentialing to hospitals and racism is not an indicator. We have to begin to call them out, right?
It's not an indicator for patients, and it's also possibly not an indicator for those who work there. So you talked about the hierarchy in a hospital. When you look at the leadership of most hospitals, what does the leadership look like? And that sets the tone. And unfortunately, in OBGYN, a lot of the leadership is male, is white, and does not include diversity, or if they do, it's an afterthought. So we definitely need change. I hope that everyone has learned something new. I have definitely learned something new from all of you, despite reading your work. And I appreciate you taking the time today to be with us here. We're broadcasting from Berlin, Germany, and we have people from New York, from California, Dr. Cooper Owens, I always forget what area in the Midwest that you moved around, so I forget. But thank you all for coming in your different time zones. It's been a pleasure to hear from you. And I think that we are all done for today. I'm sorry we couldn't answer everyone's questions. I could keep you guys on for another 10 years talking about this, but I hope that you have all benefited from the panelists' discourse and presentations, and thank you all for coming. We hope to have another webinar in the future, and it'll be about telemedicine, telehealth, and how that can actually help improve access for individuals, and that will be in November. Thank you so much for coming, all.
Thank you.
Thank
Thank you.
everybody.
Bye.
Bye-bye.
Indigenous Day in the United States.
Thank you.
Yeah.
Yes.
Thank you.